hear you.
Yeah, just we'll wait for. Shall we start the meeting now?
Yes, sir, you can start.
Okay. So good evening to all of you. As usual, I'll start with a short case first. Is my screen visible?
Oh, yes, it's visible.
Okay. So this is a short case. This case was sent to me by Dr. Ashwadi. Okay. Yeah. This is a story of a 56-year-old man. It's a known case of diabetes mellitus. History diplopia and blurring of vision on looking downwards. It was a vertical diplopia and there was no tilt of the false image. It is present looking straight down. He is also telling diplopia looking to the left and looking down, and also to the right and looking down. So it is present straight looking down, as well as sometimes looking to the right and down, sometimes looking to the left and down. He is not consistent in the site of diplopia. So that's now the complaint in this patient. The complaint is only diplopia. Now this is the video of the patient. Pupils were normal. This ocular movement, looking up and out. Ask him when to say the double ear to tell. I say no diplopia now.
Okay.
You can ask him diplopia is present or not. He said one. Now I telling double now. He said now only one. He said one. 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 See, I'll play the video once again. You can look ocular movements. Pupils were normal, reactant light. Looking up and to the left side, straight up, up and to the right. Is it no diplopia now? Is it mild diplopia at this point of time? No, it's only one. Okay. Any thoughts about which muscle is weak or some? It's not an exogenous muscle paralysis. You want to see the video? Yeah, please. Yeah.
Right inferior rectus versus right superior oblique.
Okay, perfect. Good. Right inferior rectus versus superior oblique. Very good.
Which one would you prefer?
Right inferior. Which would you prefer?
Actually, when the patient is looking left and outwards, there is more separation of the eyes, but he could not be visualizing the diplopia because it is too much florid and there is suppression of an image, if that is possible.
Okay, right. So any other test you would like to do in this patient?
Bielschowsky's test.
Okay, right, very good. Let me see. Now, this is a positional diplopia. I'll tell you the approach to the problem now for those 20 years. What you have said is all correct. Now, if you look at this position, as you all know, the right eye is up, left eye is down. That's the first step. So it could be what could be the problem now. Either the problem is the depressors of the right eye, so the right eye is up, or elevators the left eye, that's where the left eye is down. Both are possible, no? What can be in the right eye, what can be the left eye, we do not know. So if the eye is up means the depressors are weak. The eye is down means the elevators are weak. So this means that depressors of the right eye are weak, or the elevators of the left eye are weak. So right eye inferior, what are the depressors of the right eye? Right inferior rectus and right superior oblique. Or left eye, if left eye elevators are weak means left superior rectus or left inferior oblique. This much is correct, no? So these are the four possibilities you have to keep when you find a vertical separation and the right eye is up, whether we not right eye is abnormal or left eye is abnormal. These are the four possibilities. Now, which among the four is the culprit? Right inferior rectus or the superior oblique, or left eye superior rectus inferior oblique? What do you think? Which eye is at fault?
Right inferior rectus.
Among the two groups, so it could be
Right.
that point will come later on. See, in this position, the right eye inferior rectus or superior oblique is right eye is at fault, left eye is at fault. All the four muscle
Right.
weakness can be possible.
Right
Right eye
eye
is
is
at
at
fault.
fault.
Why do you say right eye is fault? I am telling it's left eye is at fault.
Because the position is looking downwards. So
Yeah, the position the left eye is looking down because the elevators are weak.
no, the
Diplopia
patient
is when
is
these muscles are
Patient
brought into
complaints of
play.
diplopia.
Pardon?
the patient is
Diplopia.
looking down. So
Ah.
and actually if his left eye is abnormal, he will not be able to. Oh, I understand the question now. But then
Yeah.
even then when he's looking down,
Yeah, doesn't
if
matter.
the right eye should be able to look down
Even
if it is normal.
No, even if looking down, if the elevators are weak on the left side, that will be compared to the right side, it will be lower down, no?
So
Is it not possible?
right eye looks normal, right eye, because there is little bit amount of intorsion on the right eye.
No, the intorsion with the static picture, we can't comment on intorsion. For
But
intorsion, you have to say the
if
movement.
you look at the length between the medial epicantral area and the medial side of the eyeball, I mean, there is little bit in comparison with that of the left side. Left
No,
side is fault.
that be no. Since the globe is round, no, in the static position we cannot detect intorsion extorsion. The only way to check
we
the
can see the
intorsion.
blood vessels. We can in the position of a dynamic situation, we can see the blood vessel.
Right. Only by dynamic movement we can see the whether is intorting or extorting. The only other way to find out the why eye is intorted or extorted is by looking at the macula in the fundus. Normally, the line between the macula and the optic disc is almost parallel. So when the macula is down or up relation to the optic nerve head, then you can say eye is intorted or extorted when the eye is not in the static position. Otherwise, just looking at the eye, whether we cannot comment whether it is already intorted or extorted, because we do not know the previous position of the vessels. Okay, so you think right eye is at fault, left eye is at fault? No, the right eye is at fault because he has got diplopia looking down. That's his complaint. If the elevators of the left eye had been at fault, his complaint would have been diplopia on looking up. Am I correct?
Yes, sir.
Yeah. So by looking at this picture alone, one cannot differentiate whether the elevators are decreased affected on the left side or the depressor affected on the right side. But since he's complaining of diplopia on looking to the right side, that means it is the looking to that means it has to be depressors. Okay, so the culprit muscle is the right eye. That much we are now certain now. Now the question is, which muscle is affected on the right eye? Is the right inferior rectus or right superior oblique? So what will you like to do? So if the patient had told that diplopia is more looking to the right, left and down, then I could have said right superior oblique is weak. The patient had said that I got diplopia more looking to the right and down, I can say right inferior rectus is weak. Because as you know, the vertical movement is best in the adducted position in the oblique and the best in the abducted position in the recti muscles. So if the abducted position is the diplopia more or disconjugation more, it is a rectus weakness. If the adducted position, the separation or diplopia is more, it is oblique weakness. So this patient did not tell that. He telling diplopia only looking down. Neither it is present looking down onto the right, nor only looking to the left. So I am got confused. So if we had set the position diplopia, we could have identified the muscle from the history itself. But you had no diplopia looking to the right and left in the downward position. So what will you do now?
Tilt his head to the right and see whether it is getting worse.
Very good. That's the thing you have to do. So ask the patient, look to the right, down onto the right, and ask him to look to the right and left, and find out the vertical discontinuity. What is perfectly right. So if superior oblique is at fault, on looking down onto the left, the right eye will be up, correct? Because superior oblique is weak. If the inferior rectus is fault, on looking to the right, the discontinuity will be more, correct? So what is said is correct. So ask the patient, look to the right and down, and left and down. Find out where the vertical separation is, vertical discontinuation is more, then that will get the clue. Let us see the point. So find out in which position of the vertical discontinuation appears. So this is a patient is looking down and to the right. So what do you think?
The other side was more.
Culprit eye is the right eye that we already sorted out. Now, the problem is right inferior rectus or right superior oblique. Now, in this position, there is vertical disconjugation. This person, no. So which muscle is weak?
And it will be right inferior rectus.
Correct. Right eye is up, so right inferior. It's perfectly right. Okay. Now let's show the other page. I'm asking the look down onto the left side. Here also right eye is up. So what does this tell you? Right superior oblique weakness. Correct? So,
Yes.
so either way, I can't differentiate because right eye is up in the adductor. If there is a difference, I could have been, it is easy for me to differentiate the two. So whether it is right superior oblique as in this patient shown here, or as shown here is right inferior, this is a problem. So what should I do now?
Head tilt.
Correct, perfect, head tilt test. So vertical disconjugation remains the same in both the directions. So this is the test. What is the name of the test? Bielschowsky's head rotation test. So closely watch what I have done now. See? And ask him to say whether the diplopia is maximum.
ഇനി ഞാൻ കണ്ണ് അവിടെ തന്നെ എൻ്റെ പേരിൽ തന്നെ നോക്കാം ഞാൻ തല ചരിക്കും
I'm looking, ask him to look at my finger.
കൂടുന്നെങ്കിൽ പറയണം
Ask him to when the diplopia is more and there is going.
അങ്ങോട്ട് തല തിരിച്ചോ തിരിച്ചോ
And turn to the left side.
ചരിച്ചോ 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 ഇപ്പൊ അകന്നു കൂടിയോ കുറഞ്ഞോ
It is less now.
കുറഞ്ഞല്ലോ രണ്ട് വിരൽ കാണാമല്ലോ കുറഞ്ഞു ശരി ഇനി നോക്കി
Turning to the right side, rotating to the right side.
ഇപ്പം കൂടിയോ കുറഞ്ഞോ കൂടി രണ്ടായിട്ട് കാണുന്നുണ്ട് രണ്ടാണ്
Saying double now on
ഇപ്പം
the left side again.
രണ്ടായിട്ട് കാണുന്നില്ല എന്ന് പറയും
He's not saying double now.
രണ്ടായിട്ട് കാണുന്നില്ല അതാ പറഞ്ഞേ രണ്ടായിട്ട് കണ്ട ഉടൻ പറയണേ വെള്ളത്തിന്റെ തുമ്പിൽ തന്നെ നോക്കിക്കോണം രണ്ടായിട്ട് കണ്ട ഉടൻ പറയണം രണ്ടായിട്ട് കണ്ട രണ്ടായിട്ട് കാണുന്നുണ്ടോ ഇല്ല രണ്ടായിട്ട് കണ്ടാ പറയണേ വെണ്ണ തുമ്പത്ത് നോക്ക്
He's saying double now.
ഇപ്പൊ രണ്ടായി മുഴോട്ട് താട്ടും അല്ലേ
That means what he's telling is that on tilting the head to the right side, he's seeing double. On tilting to the head to the left side, he's not seeing double. So, which muscle is at fault?
Superior oblique.
Correct. It's right superior oblique. The idea is, so superior oblique is an indautor, inferior rectus an extortor. The idea for the Bielschowsky test is to put the muscle into action, weak muscle into action. So if you, how will you put the superior oblique into action? Tilt the head to the right side. So when you tilt the head to the right side, the right eye indauts, left eye extorts. Correct? Same side I will indauct, left eye, opposite eye will extort. If you turn the head to the left side, what will happen? The left eye indauts, right eye extorts. So when I put the head to the right side, what happened? The eye should have indauted on the right side, but the superior oblique is not acting. So what will happen? The eye will further move upward and the diplopia will become more. Okay. If the inferior rectus is at fault, nothing will happen when you turn the head to the right side. So this test tells you that it is most likely right superior oblique. Now, diplopia is more on tilting the head to the right, absent on tilting the head to the left side. Diagnosis, right superior oblique palsy. What would have been the situation if it were the right inferior rectus? What will happen if in the Bielschowsky is tested? A test. Because you have to put the inferior rectus into action. The inferior rectus is an extorter on the right eye. So how will you extort the eye? Tilt the head to the left side. When you tilt the head to the left side, left eye intort, right eye extorts. So in this patient, if the diplopia had been more on tilting the head to the left side, the right inferior rectus is weak. If diplopia is more to the right, turning the head to the right side, putting the right intort into action, it is right oblique, is the parallateral muscle. Have you understood what I said? Because we are utilizing the torsional action of the oblique and recti to find, we cannot judge by the vertical action, because vertical action on either side is almost same, so we can't say which muscle is weak. So we have to utilize the torsional action to find out which muscle is weak. And if you want to repeat, I will tell once again clearly. If you understood, we can go ahead.
Sir,
So
can
once
you
again.
repeat?
Yeah. I'll tell you. Yeah. The basic principle of Bielschowsky's head rotation test is that you have to utilize the torsional action of the ocular muscle. See, the superior oblique and inferior oblique and superior inferior rectus are torters. They can rotate the eye. Normally, you cannot check the rotation by looking up and down, because it will be combined action will occur. Now, suppose you want to see the torsional action, the other muscle should be weak. So, for example, suppose in the usual exam question, what is asked? How do you examine the superior oblique in the presence of a third nerve palsy? That's usually MD question, or DM question they ask. Because how would you normally check superior oblique? Ask the patient look to the medial side or adduct and look down for superior oblique, look up for inferior oblique. Because in the adducted position is the vertical movement of the superior oblique. So that is a ideal position for the superior oblique and inferior oblique to produce the vertical movement. Okay. For the torsional movement, it is abducted position. Forget about that thing. So in third nerve palsy, what will happen? Patient eye cannot be adducted. Then what will you do? You cannot look for elevation depression for superior oblique and inferior oblique. So there what we are using, suppose superior oblique is weak. You ask the patient, look down, that eye will go into extorsion, or if superior oblique is intact in a medial rectus palsy, the eye will intort. Why is intorting? Not because superior oblique is acting, but because the inferior rectus is weak. Normally, when you look down, both your superior oblique and inferior rectus is acting. So both are depressors. When both muscles are acting together in the normal eye position, suppose you are looking down, for both superior oblique and inferior rectus acting on that eye. Okay. So why the eye is not rotating? Because one is an intorter, one is an extorter. So it will be nullified. So you get a smooth downward movement in the eye. Suppose inferior rectus is weak, the only downward movement which is done by is a superior oblique. So superior oblique, what is its action? Not only depression, torsional action. So in an attempt to depress the eye, it intort the eye. That is what we are utilizing in the case of third nerve palsy. So the eye goes to look for the torsion. That's why I say third nerve palsy, look for torsional movement, to put torsional movement. That is because the inferior rectus is weak. Okay. Suppose here superior oblique is weak in my right eye. Okay. How do you check my inferior rectus power? Again, look at the downward eye. So, as told before, superior oblique is a depressor and intorter. Inferior rectus is a depressor and extorter. See, my superior oblique is weak. On looking down, the eye will extort, because superior oblique is not acting. So inferior rectus can act as the extorter only if the superior oblique is weak. So that is the action of the oblique. Now let us come to this thing. Normally you cannot put the torsional, check the torsional action. The only way by which you can voluntarily look for the torsional action is by the ocular counter row. What is ocular counter role is that suppose you want to see something there straight ahead. You are seeing a person in straight. Suppose you look from the left, turn the head to the left side, still you are seeing upright. But turn the head to the right, still he is saying upright. He's not tilted. Why is not tilted? Because eyeballs make a compensatory rotating movement. So when I tilt the head to the right side, the rotation should be the opposite side. Then only I can see the person intact, straight as upright. Otherwise, I will see him is also tilted. But we don't see him tilted because of the eyes makes a compensatory rotational movement. That is called the ocular counter roll. So what should be the counter roll? When I tilt the head to the right side, the right eye should intort, left eye should extort. Okay, and I will on the intorting, I will also slightly move upward. This will move because the head is down now. Head is not, so little move upward, intort upward. This I will extort and move a little down. Forget the downward movement. So this is the action we are utilizing. This reflex is the one which is utilizing. That's the basis of the Bielschowsky's head rotation test. So in our patient, we have got two problems. Suppose this particular patient has got a superior oblique palsy. Imagine that thing. So I want the right eye to intort. Okay. If superior oblique is weak, that eye will not intort. Okay. The only other intorter is the superior rectus. Okay. So when I tilt it to the right side, it may normally tilt to the right side. The right eye intorters mean the intorters are superior oblique and superior rectus. If my right superior oblique is weak, it would tilt to the right side, only superior rectus is acting. What will it do? It will elevate the eye because it is acting unopposed of the superior oblique. So in torsional movement, normally only torsional movement, no upward and downward movement because superior oblique is a depressor, superior rectus is an elevator. So here what happened to the right side when superior oblique is weak, only superior rectus is attempting to intort the eye. In an attempt, it will elevate the eye. Already the right eye is elevated because superior oblique is already weak. The depressed weak. So superior rectus acting alone without the action of superior oblique, the eye further, not only that the intorsion moment is weak, it goes up. So the diplopia become more prominent. So the idea is to put the weak muscle into contraction. Suppose you want to make the inferior rectus into contraction, what will you do? You have to extort the left eye. What is the position left or left eye? So it's still intort only, right, left, right eye. You turn to the left side, this eye intort, this eye will extort. There, inferior rectus is put into action. Suppose if right inferior rectus is weak now, I'll tilt to the right side, nothing will happen because inferior rectus is not put into action. The right eye is intorting only superior rectus and superior oblique is put into action. Suppose you tilt to the left side, right intorters are not working. They're not acting. It is the extorters should acting. Which are the extorters? Inferior rectus and inferior oblique. See what suppose inferior rectus is what happened. Only inferior oblique try to extort the eye. Inferior oblique in attempt to extort the eye will move upward because inferior oblique is an elevator. So what will happen? Eye still further up, diplopia will be more. Okay. So because the other muscle is not acting, inferior rectus is not acting. So if right inferior rectus is weak, the principle is same thing. Which is suspected muscle, put that muscle into action. How will you put the muscle into action? Use the torsional movement. If the extorter is weak, put the eye into extorted. That will turn it to the opposite side. This will extort. If intorter is weak, put the eye into intorsion. Turn it to the same side. Make the intort the eye. So that's the principle. That is why I am telling you in this particular patient, in all superior oblique, this is the thing which you should think superior oblique which you come across. Right superior oblique is weak, you put them into action, the diplopia will more when you turn to the same side. Because right eye is intorting. The eye which is the side in which eye is tilted, that eye will intort. Am I clear to you?
Yes, sir. Thank you, sir.
Yeah. Okay. If you go and think about it a little later, you can really easily understand these things. So if inferior rectus is the culprit, diplopia should have become manifest if you had put the eye into extortion. Because right eye goes into extortion when you tilt the head to the left side. Same thing which I told just now. So the right inferior rectus at fault, he would have complained of diplopia on tilting the head to the left side. Here is complaining on diplopia and to the right side. So the inter-aorta is weak, that is superior oblique is weak. Not the inferior rectus, because the inferior rectus is next aorta. Now look at the screenshot of the right eye is gone up now compared to the left eye. That again shows superior oblique is weak. But in this position, he did not complain on diplopia. He would complain on diplopia in this position, the diagnosis would have been very simple for us, but he did not complain of it. Okay, so any questions in that case?
So during the performance of the Bielschowsky head rotation test, you are asking the patient to fix the target to your finger. So the finger should be in central position or in the direction of maximum diplopia.
And in the maximum diplopia, for example, suppose you are suspecting is right superior. Wherever he complained of the maximum diplopia, that will be the position of the your finger. Then ask the patient tilt to the right and left side. Okay, suppose your right superior oblique is weak. Ask the patient look at the diplopia is usually they complain of looking down and down and in. Keep the finger there. Okay, that finger diplopia is there. No? There'll be more when you tilt the head to the same side. It disappears when you turn to the same side, to the opposite same way, rotate to the same side. My right eye is affected means right superior oblique is weak. I have to intort the eye. To intort the eye, I tilt to the right side. The right eye will intort. The diplopia will be more. If you touch the left side, the diplopia will become less because this superior oblique is not active.
So suppose the left elevators were weak in this case, so we would have put the gaze position in the upper visual field, the target to be fixed. Sir. In the upper visual field is the left elevators.
In the case of?
So if this patient would have had left-sided elevator weakness, then we would have fixed the target in the upper visual field to check for the head rotation test.
Right. Wherever he complained of diplopia, that position you have to put the finger. Then you rotate and find out whether it disappears or worsens.
Okay, sir. Thank you, sir.
Okay. So, any other question? Now, very often this test comes in handy because by this simple bedside you can make superior oblique most of the time 90% is benign condition. So you don't do so severe investigations and all. Now let's go to the next case. Now, shall we go to the next case? It's a long case.
Sir.
Yeah. So this is a story of a 77-year-old female. So keep a clean, concentrate on this particular case. This is a very interesting patient. He was admitted with a history of walking difficulty in the form of imbalance for the last 2 weeks. No history of any numbness or bladder problems. In fact, in the past, she was seen by me with walking difficulty 9 years back. But she lost all the prescriptions and the investigations done at that time, except for the old MRI, which she did not bring at that time. She said with that treatment, she became moderate, the imbalance will improve. So that way, not bothered to come for follow-up and out. Now she has come with difficulty in walking for the last 2 weeks. So at that time, that 9 years back, when she had consulted me, she had been put on treatment and cervical collar, and the walking difficulty apparently improved almost totally till 2 weeks back with the present complaint. But one more story is there. In fact, I had seen her 1 year back for some other complaint. 1 year back, she was brought to me again for memory problems, and she was diagnosed to have early dementia. Because I have diagnosed Alzheimer's disease and put on donepezil since that time. Probably I must have done MRI brain at that time, whatever it is. That prescription carried the diagnosis that old case of OPLL causing mild cervical myelopathy. That was the diagnosis which I had made 9 years back, and the prescription which I saw that only 1 year back when the patient came for dementia checking, memory problem testing. I had written this particular, apart from memory loss and this thing, I had written old case of OPPL, OPLL causing mild cervical myelopathy. That is the only prescription. Now, this is the present admission when he has come with walking difficulty. This is you want the history once again? I'll tell the history. Presently admitted history of walking difficulty in the form of imbalance. In the past 9 years back, she had some similar walking difficulty, which improved with cervical collar and treatment. 1 year back, she was seen by me for early dementia. And that time, and that prescription carried the diagnosis of old case of OPLL. Now, this is the present admission, which I 1 week back.
ഇവിടെ നോക്ക്
Canines are all normal, local and mom is normal. Lower canines are all normal.
കല്യാണിച്ച് നാക്ക് നീട്ട് ആന്ന് പറ ആ മതി
Now go to the proper main part of the examination.
ബലം കൊടുക്കല്ലേ
Tone was normal in the upper limb.
എന്തൊക്കെയുണ്ട് ബലം കൊടുക്കല്ലേ മുറിച്ചത്
Cantrip was good. Deltoid was normal. Triceps was normal.
പിടിച്ചോ അങ്ങനെ പിടിച്ചോ
Small bristle power was also normal.
ഇനി വിട്ടോ അമ്മ ഇനി വരല് തൊട്ടെ
There was no finger nose incoordination.
മൂക്ക് തൊട്ടെ നിമ്മയിരുന്നു
She see the difficulty in getting onto the bed. She was sitting. She cannot put the legs onto the table to the cot by herself.
എഴുന്നേറ്റ് മടക്കമ്മ
The neck muscle appeared normal. She could not putting a pressure on the thigh. She could not get up from the lying, sit up from the lying position. Tone of the lower limb appeared normal. There is weakness of hip flexors about just 2 power. It falls down. But knee extensions are also weak, but little more powerful than the hip flexors. About 3 to 4 power. Dorsiflexion was 4 to 4 plus. It was better power compared to the knee extensor hip flexion. So 4 plus power is there. That's also good power.
ഇതും ചവിട്ടിക്ക്
He could press it down.
ഇത് ചവിട്ട് ഔട്ട് ആദ്യം തന്നെ ചവിട്ടി പിടിക്ക് ആദ്യം
He could press it down. The abduction and adduction was weak.
സമ്മതിക്കില്ല
Adduction was also
അടുത്ത
weak.
സമ്മതിക്കില്ലേ
Reflex upper limb reflexes, biceps normally elicited.
ചുമ്മാ ഇട്ടാ മതി കേട്ടമ്മ
Slightly brisk supinator. You can see the finger flexion coming now. See the finger flexors are coming with supinator testing. Triceps was normally elicited. Finger flexion was brisk. Knee jerk was also brisk. It's a crossed adductor jerk. Angle jerk was on the right side was absent. A flicker only. Left side was well elicited. Not brisk, normally elicited. Plantar right is indefinite. Left plantar up, and you can see the clawfoot deformity on the left side. And the left plantar is definitely upgoing. It's undoubtedly upgoing. The sense is normal in the upper limb, normal in the lower limb also.
ശരി ഇത് വ്യത്യാസമുണ്ട്
But pain, she's telling, decrease in the lower limb.
ഇതും വ്യത്യാസം ഉണ്ടാവും
Is lesser.
കുറവാണല്ലോ
On checking the pain upward, she will point where the pain is. There she is feeling the pain.
അങ്ങനെ പറയണം അവിടെ കൂടി
Somewhere around D4 level.
വേറെയല്ലേ അത് കൈ കൊണ്ടാ
Vibration is able to appreciate normally in the upper limb.
ഒന്നുകൂടെ ഇല്ല
They is not able to feel,
ഇപ്പോഴോ
not able to feel in the shin.
ഇല്ല
The anticipatory spillage also is very mild.
നില്ല ഇപ്പോഴോ
He said no.
ഇപ്പോഴോ
That is very markedly very well elicited, seen, appreciated in the sternum.
ഓക്കെയാണോ അത് ഈ
The joints appears normal in the upper limb. Lower limb is totally lost. Even the wide range of movement she could not appreciate.
അനീ ഓടം പറയണം
Normally 5 to 10 degrees, even at 90 degrees, she is not able to appreciate. I am asking to tell when it's moving, it's not able to tell that thing. So on examination, high myelopathy, recent episodic memory loss. Rest of the high myelopathies were normal. Cranials were normal. Motor upper limbs, normal tone of both upper limb. Power grossly normal in the upper limb. Lower limb, grade 2 to 3 power of hip flexors, hip adductors and abductors. 3 to 4 power of knee extensor. 4 to 4 plus power for the dorsiflexors, plantar flexors and EHL. TTR, both upper limb, biceps supinated, triceps normal bilaterally. Triceps reflex right side is well, left side is slightly less. Finger flexion is briskly elicited. Knee jerks were brisk. Left angle was normal, right is absent. There was clawing of the left foot. Plantar's right is indefinite, left is extensor. This is the reflexes, biceps normal, supinator is normal, triceps is less on the left side, finger flexion is brisk. Knee jerk is brisk, right angle is absent, left angle is 1 plus. Abdominal reflex I did not check. Plantar, right is indefinite, left is upward. Sensation touch normal in the upper and lower limb. Pain impaired below D4 level. Vibration in the upper limb normal in the normal in not the upper limb, not lower limb. I typed it wrongly. In the lower limb, it was impaired in both the lower limbs, including the anterior superior iliac spine. Normally felt over the lower sternum. JPS normal in the upper limb, severely impaired over both toes. She made to stand, she buckled on made to stand, and Kate could not be tested. So, where is the localization in this patient? If you want the finding once again, I will tell once again.
Sir, hip extension abductor, sir.
I'll tell you. Both hip flexors were weak. Hip extension was also weak. If hip extension was also weak, hip abduction adduction was weak.
So there is suggestion of both peripheral large fiber involvement as well as posterior column involvement in this patient.
Correct.
So
but
the
you
higher
remember that patient has got proximal muscle weakness is more than the distal muscle. The proximal knee jerks was brisk and one plantar is upward.
Yes, sir. That's why the cord involvement cannot be ruled out.
There is a sensory pain level somewhere around D4. So spinal cord is definitely affected.
There are two sides of lesion. So one is at the dorsal cord, which
Correct.
explains the pain level and myelopathy symptoms. But there is also some element component in the right ankle is absent and left clawing muscles.
Very good. So that is one part. What you said is correct. So yes, got myelopathy plus peripheral problem, maybe radiculopathy, neuropathy, myelopathy. Where is the site of myelopathy? Is upper limb reflexes where fingerprints are brisk, triceps left side is slightly less, but power sensations are normal in the upper limb.
More of dorsal only, sir, D4 level.
Okay, right. But initially, I had seen her 10 years back. At that time, I diagnosed cervical myelopathy and was diagnosed OPL. And she was put on a cervical collar. That is the old story.
Cervical, cervical, because finger flexion reflexes present.
Yeah, it could be cervical as well. We cannot be totally say because the finger flex also brisk. By progressive lesion, sometimes the sensory loss may ascend up later on. But as you said, it's correct because usually there is no sensory in the upper limb. So that's more likely dorsal also. But cervical cannot be ruled out with a past history.
Finger flexors are brisk, so probably
Above
the level above C8.
Yeah, correct. That's
Probably. And there is probably an additional radiculomyelopathy component because that proximal muscle weakness cannot be explained
by cervical. Perfect. Right, perfectly right. So there are many odd points for a straightforward diagnosis, correct? So he has got a myelopathy, but we can't explain the proximal muscle weakness more than the distal muscles. At the same time, there is no clear evidence of radiculopathy of proximal muscle because that reflex is slightly brisk. And there is one clawing on the foot on the left side. They indicate definitely small muscle involvement. Right angle is decreased. That cannot be explained cervical myelopathy. Maybe an older woman, maybe unrelated lumbar spondylosis. There are many things you have to keep in mind. There may be comorbidities also. So you have to investigate to find out what is the thing. So these are the findings now. This I've already told. So these are the things: myelopathy above C5, myelopathy with other possibilities, myelopathy with right S1 radiculopathy because the right angle is absent. How to explain the left foot? Maybe left S1 is to radiculopathy as well, or maybe an unrelated torsional syndrome. We do not know. These are the possibilities you have to keep in mind. Now, what will you do now? What do you want now?
First, for an imaging,
Okay, what imaging?
MRI of the cervical, the
Okay.
entire
Whole
spine.
spine.
Okay. Okay. Whole spine being because it will be too costly, no? That here every part will cost about 5,000, 6,000. If you take whole spine, they will charge 15,000. Not only 15,000, 18,000 they will charge.
But
So the
Anyway,
pectoralis jerk was tested in this patient, pectoralis jerk.
pectoralis sac I did not. I usually don't do pectoralis sac because it does not have a high localizing value at all. Because it has multiple route supply for the pectoralis muscle, C5 to D1. So C5 to C8 at least. So it's not going to help us much. I don't do that. If at all we can do this suprascapular reflex, that is, if you have that reflex, it may be little more helpful.
There was bladder involved.
No bladder involved. She did not complain of bladder involved. So what I did was, first thing I wanted to bring I bring all my MRI back. She probably the person brought the MRI, which had taken 9 years back. So this MRI, which I'm going to show now, is taken 2014. This is the MRI at that time. It's got it is some lesion anteriorly and posteriorly there, long hypointense lesion, king in the upper cervical cord. This is the axial T2, so the hypointense lesion anteriorly compressing the cord. This was 9 years back, remember. This is the T2 again. So the lesion is extending down up to C6, C7. There it is much less. C6, C7 level, the cord compression is not there. Up to C6, C7, it is coming. Lower C6, C7, it is not there. This is still sequence. Again, you can make out from C2, C3. Cord is compressed there. C4, C5, C5. You can see this is a T1 sequence. So it is hypointense in all sequences. T1 and T2 all. That whatever compressing that. So what is the diagnosis now?
So is the cord bulky, sir? Looking very bulky.
No, the cord is not bulky. Cord is compressed.
In the sagittal section.
Okay, I'll come to the sagittal section. Just 1 minute. No, here
It looks bulky, no?
No, this is the normal cord that is getting compressed both anteriorly and posteriorly. It's not called bulkiness. This is the lesion there. From here to here.
OPL.
So most likely OPLL. In
So
fact, that's
OPLM with ligamentum flavum hypertrophy.
yeah, correct. Perfectly right. So OPL alone cannot explain because OPL will not occur posterior compression. So ligamentum flavum hypertrophy. So in fact, that's the thing that's the diagnosis which I written earlier, and he improved with steroid, probably might have given steroid and cervical column. Now this is the old MRI. Okay. This is the lesion I am trying to show you, and the ligamental flow hypertrophy. This is a lesion in detail. So, what would have been diagnosed at that time? Most likely OPLL. That's what I also thought. Now, this is the MRI report at that time, 9 years back. And this is done by an expert lady in radiology. She said marked posterior thickening at C2 to C6 level. Significant stenosis in the cervical region. Some linear ill-defined hypernescot signal T2. I couldn't see that anyway. Okay. So anything odd in the diagnosis of OPLL? Already said, because there is a posterior lesion cannot occur with the OPLL. Okay. So the CT scan was done at that time. And this is a CT scan. That lesion is not calcifying.
Yes, sir.
There is some hyperdensity there, probably in the beginning of a calcification state or not, but there's no, we can't call it OPLL with the CT scan. But I did not, I overlooked that finding at that time. I also thought this is CT scan, this is OPLL.
That case, it could be iron if it is not, because it is T2, T2 it is hyperintense.
T2 is hypointense.
But it is not seen in CT. So it should be something like iron deposition, which can.
Right. Yeah. But the problem is that sometimes, some particular calcium pyrophorate crystals and all, that may not be picked up in CT all the time. So that's what is said is correct. So iron, manganese, etc. You have to keep in mind with that this thing. That may not be picked up in the CT scan. Correct. That's a point. But what lesion there with iron containing lesion you can think of?
Something like IgG or.
Yeah, that's a very good possibility. IgG4 disease. That any highly cellular lesion is possible. But patient remained asymptomatic for 9 years without any treatment. Okay. Now
superficial cirrhosis.
Well, a superficial cirrhosis will not occur like this. That will be lining the cord longitudinally. This is a thick lesion compressing the cord. It's wide. That's not superficial cirrhosis. It will be only lining the leptomeninges by the cirrhosis. This is a small hypodense which I could make out from this. See that one slightly, some calcification may, okay, by imagination you can think it may be calcification. Okay, now question is, what is causing her inability to walk?
So is she CKD patient?
Pardon?
Chronic kidney disease patient, is she?
No kidney disease.
Proximal muscle weakness is responsible for that.
Yeah. Proximal and distal is also weak, proximal more than the distal. So is it recurrence of cervical myelopathy in our patient or myeloneuropathy? So like something like a subacute combined degeneration. And the picture I showed was the old one, not the recent one. Recent one I'm going to show it. And myeloradiculopathy with the absent angle check and clawing with the left foot. So these are the things which should come on your mind. Why is come with the weakness now? The same lesion has progressed, or a new lesion has come somewhere. It may not necessarily be compressive, maybe myeloneuropathy, only 2 weeks duration. Myeloradiculopathy, because the previous lesion remaining quiescent for 9 years, how should it suddenly increase for 2 weeks? That's also something very odd. So you have to think out of the box, think of other etiology, need not necessarily be compression and all. Okay, what do you want now?
Present MRI, cervical.
Pardon?
Repeat the MRI, sir.
Repeat MRI.
Contrast.
Okay, repeat MRI contrast. This is the repeat MRI cervical spine. The lesion is same, not much of a difference. This is the sagittal cut. This is the axial cut. That is anti-decompression.
The lesion is reduced now, sir. The number of segments.
Apparently looks like reduction from the previous one. Correct.
Rest of
This is
spine is
this you can see some of a hyperintensity here now. See in the back. Did you see that? Some
Yes, sir.
okay.
But still, there is no ossification, sir. There is no ossification. We cannot tell OPLL still.
You're perfectly right. You're perfect, 100%. There's no ossification. Some hyperintensity there. That's all. That could be, as you said, highly cellular tissue. Anything may be possible. So, anything else you want now?
NCS, yes.
No convection study.
NCS, because no, we couldn't find that the particular cervical lesion is not responsive. That is very definite.
Sir,
what
rest
about
of spine you have not done?
Pardon?
Rest of
Rest
spine.
of spine.
You want? Okay, I'll come to that. But what do you think at this point of time? Let us see. NCS was done. To find out whether it's a minor neuropathy is one thought we have to keep in mind because maybe unrelated to weeks. Okay, that NCS is normal. So what else you need now?
So dorsolumbar spine with contrast.
You've
Okay.
shown the snap, sir. Snap is normal.
Snap is
Snap is
normal.
normal.
Normal. This is snap.
So then radiculopathy is a possibility.
Yeah, it could be radiculopathy. That's why I took lumbar. I'll come to the spinal. So in fact, when the patient came, I sent these things investigation also serum homocysteine and beta peripherals were also sent and the OPD itself because I had thought these are the possibilities you have to keep in mind. So the result came, homocysteine is normal, peripherals may no hyper everything. But the ESR came as 115. Very high ESR. And ANA profile was also sent, that is also negative. Because this was sent after seeing the high ESR. So ANA profile was also negative. What do you want now?
CSF
So what
study.
is CSF and what before that? Let's see what is again cervical cord compression in this patient. Her proximal muscles were more weak compared to the distal muscles. And how can you explain by a pyramid? Can pyramidal lesion produce more proximal weakness compared to the distal muscles? By any means?
If the medial
Venous
part of the
congestion
corticospinal tract is
Medial part.
Medial part is affected, you can have a proximal muscle weakness. So still lesion may be in the spinal cord. Right? Why I'm not thinking for radiculopathy or a peripheral neuropathy in the lower limb is that the maximally affected muscle has got brisk reflex. That is then hip flexors, knee extensors. So that makes it unlikely, more like a pyramid, and moreover one of plantar sub going also. So that looks me more like a pyramidal lesion. So if it's a pyramidal lesion in the cord, you have to think of something intramedullary also to be kept in mind. Okay, let us see. So one way have to think of intramedullary lesion in the cord affect the middle part of the dorsal cord, or associated radiculopathy as you're thinking, proximal root involvement more than the distal one. But the odd point I've already mentioned that the reflexive risk. So what do you want now? Dorsal lumbar spine, correct? Okay. This is the dorsal spine. There is lesion there in the dorsal cord. Again, something similar to the cervical one. I'll show the one cervical cord lesion. Okay, I'll show the similar picture. This is the T2 axial. Look very carefully. This is the T2, remember T2. Coming down to the conus, epiconus region. That is a conus region. Okay, so what do you think about seeing the MRI? It's an axial cut. I will show you once again.
Sir, is this normal, sir? This black thing around the cord, sir?
Yeah, that's a black thing around the cord. I'll show you once again. I'll show the screenshot picture later on. So here there is something which see that some area CSF is not seen. CSF is totally obliterated and retained by a black thing surrounding the cord. And there is a hyperdensity within the cord also. Did you see that? So
Yes,
that could explain the proximal sleep.
Yes, sir.
So cord is compressed from outside because that is CSF space there. Moreover, there is a hyperdensity within the cord. So probably secondary myelitis or some ischemia is called secondary to the compression. Whatever it is that is there. That could explain the proximal muscle weakness. So this is the sagittal stir sequence. Okay, this is the lumbar spine, normal. So what do you find? Some long extramedullary lesion encasing the lower dorsal cord. Will you explain the proximal muscle weakness? No, because compression cannot, the outside compression cannot produce a more proximal muscle weakness. Let us see, you can find the hyperdensity within the cord inside, the sagittal cut, and also in the axial cut. So there is intramedullary lesion, hyperdensity, that could explain the more proximal muscle weakness. But more interesting, what is the diagnosis now? Thoracic pachymeningitis. Okay. Or OPLL. OPLL thoracic, but again unlikely because why OPLL is unlikely now? The posterior part.
Calcification could happen.
Posteriorly, it is there. Sir.
Correct.
In case.
Yeah, there's hypointensity in the posterior aspect also. It's surrounding the cord. I'll show the picture once again. See this present posteriorly. That cannot occur with the OPLL. So CT of the spine again showed no calcification of the dorsal spine also. It is not OPLL. No calcium. So what is the diagnosis now? What is the point against OPLL? There is hypointensity in the posterior aspect of the as well. No calcification. Now is it pachymeningitis now?
Yes, sir.
Yeah, it is pachymeningitis. Now let us see this screenshot once again. Hyperdensity within the cord. Another cut. Now look at what is happening now. Markedly hypointensity thickened dura. When it comes down, the dura is become more thickened, and the spaces space become more narrowing. That's the thickened dura. Now here the CSF is totally obliterated. The entire thickened dura is surrounding the cord without any CSF space. Again, you can find thin rim of CSF, rest of things a thick, dark dura. So what else you need now?
CSF.
Yes, sir.
CSF.
Contrast MRI.
Okay, contrast MRI, very good. So contrast study of the cervical spine was done. The contrast MRI. There is no contrast enhancement to the lesion. So if it was lower down, you say pachymeningitis. The upper part, what is that? It should be pachymeningitis, but there is no enhancement of the cervical part. Unlike to be pachymeningitis in the cervical region. Now let us see the dorsal spine. This is the dorsal spine. See, thick, dense enhancement of the dura posteriorly and anteriorly. I'll show the picture once again. And I'll see the type of enhancement. See, it is here, it is thickened, something like a notch, like as the cord is compressed in an irregular fashion, both posteriorly and anteriorly. This is another cut showing the thickened, enhancing dura. Look at the axial cut now. See, the cord is all compressed around this enhancing. What you're seeing is enhancing tissue around the cord. That area is concentrating. I'll show the screenshot later on. See, that is the cord kinked, surrounded by the enhancing dura, thickened, and the cord is chinked all around. And there is some hyperdensity within the cord also. And that part also is enhanced. So this is a report, extraaxial dural-based ventral and dorsal hypoenhanced enhancing lesion. Cord shows swelling, diffuse intramedullary hip to appendicity, maybe secondary myelitis. This is cervical spine. Same thing, but no enhancement. So what is the diagnosis now?
Sir, IgG4 is done, sir.
Okay, let us see. What else before we go in orderly fashion? What else you want?
Yes, sir.
Thickened enhancing meningitis can be to many things, no? See, pachymeningitis can be tuberculous, can be to sarcoid, can be due to IgG4, can be due to malignancy also. These are all human, which is coming with this thing, lymphomas. So, what do you want? CSF.
Yes.
So, this is CSF shows endochromic fluid. Okay. CSF protein is 576. CSF glucose is 31. And cells, 11 cells, lymphocytes. TB-PCR is negative. Cytology for malignant cells negative. So what do you want now? Sarcoid?
Yes, sir.
Yes, sir.
Okay. Okay. ACA level normal. CT just no hyaline lymphadenopathy. What do you want now? CT abdomen was done. And this is CT abdomen. I did not pick up this finding. Radiologist pick up this finding. He found something abnormality around the aorta.
Calcification of the aorta.
See, there's a calcification. But outside the calcification, he paid out some finding. That he's pointing out the what do you call the arrow pointing to that thing. I'll show this as a screenshot later on. So CT abdomen showed one particular finding. And there's a soft tissue.
Pancreatic, sir. In IgG4 we get it.
Very good. Previously, the doctor was also telling IgG4. So
Yes.
this was said to be very characteristic of IgG4. Frankly, I did not know this finding was an IgG4, but that is what he said. If you find something lesion there, that's typical of IgG4. So even before we have already sent from the very beginning, the IgG4 was sent, but it takes time for the result to come. The cytology of result came earlier, IgG result did not come. So I put the patient on, by seeing the abdomen CT, put the patient on treatment. Now this is after 5 days of treatment. The power has become better. Even see the hip flexion, which is not possible in these days. The pulse has become good power now. The distal part remains the same because even before also it was a good power. Reflexes, knee jerk remain brisk. The angle jerk, which is absent earlier, has become acceptable now. With the right angle jerk now. The case came back. The rest of the finding remains the same. So treatment given was IV methylprednisolone. In fact, the radiologist has made this diagnosis. Mild aortic wall thickening note to the distal aorta near the bifurcation and right common iliac artery, choroatherosclerotic trauloid periaortitis, IgG4 or autoimmune. So IgG4 was elevated. So that is the story of so that's the story of this patient. Now question is not that. Then what happened to the cervical lesion? What are the cervical lesions the patient had been having for 9 years? And why that is not enhancing?
No, at that time you might have given some treatment, no, sir.
Yeah, I must have given steroid. But
Yeah.
that's only for, I give it only for a short duration. The patient loss of follow-up for 9 years, no treatment. And why that, if it is IgG4 causing that thing, why it's not enhancing?
That has gone, sir. That is resolved. IgG4 can have like that, sir.
Exactly. What is it? It is correct. So in the healed lesion, sometimes may not enhance. Only the active lesion will enhance. So that is an old. What is lesion did not enhance? Most likely is a burned out pachymeningitis, burned out IgG disease. There remain only hypointense without enhancement. What you're seeing now, 2 weeks what the patient come with an active lesion in the thoracic cord. That is IgG4. That is why it is enhancing like that. It is something circling the cord. I have found similar one case before with something which is encircling and what you call or strangulating the cord all around. That turned out to be lymphoma previously, which I had seen. So that this I also consider that possibility that is central malignancy is not possible. Only the radiologist picked the abnormality in the aorta that told me that showed that this could be more like IgG4. So that's the story of the patients. Any questions?
So the patient also had higher mental function abnormalities. Was MRI brain done, sir, for the patient?
Yeah, it was done. It was done. That 1 year back, she came with memory impairment. MRI brain was done. That showed atrophy. That is why made a diagnosis of Alzheimer's disease. And that is remaining like that. The problem why she has come to me was only because unable to walk, not because of the worsening of any high malnutrition problem. This time I did not do the MRI brain.
So why did you take CT spine to rule out OPLL?
Yeah, because of the calcification. To rule out, sometimes calcification may not be picked up in MRI, so you can differentiate it. But T2 hypointensity can occur in calcification as well as any dense fibrous tissue or a highly cellular tissue, all can produce T2 hypointensity. Apart from, as told before, iron, manganese, etc. They are all paramagnetic substances which can produce hypointensity in T2. Usually the lesions produce hyperintensity, pathologic hyperintensity. There are certain things which produce hypointensity. One is iron, other is calcium, bone, thick fibrous tissues like dura is hypointense, and any lesion which is with a less water content. There are some highly cellular tumors like lymphoma, which is highly cellular, or meningioma, or granulomas. They also appear hypointense in T2. So that is why the T2 calcification, to rule out calcification, we took a CT scan. But the other will not be hypertense in the CT scan.
So the clawfoot is incidental, sir.
Pardon?
The clawfoot, sir, is it incidental or chronic one?
I do not know. Maybe I do not know. See, maybe it's most likely incidental only. In fact, I did not specifically study the medial lateral plantar.
So this amount of protein elevation in the CSF, is it because of the secondary cord compression or because of the inflammatory process?
Which one? High protein.
So the high protein, sir.
More like mostly the cord compression. The inflammatory process is the culprit. It should have been much more. Cells will be very good. It's only 11 cells.
Yes, sir. Yes, sir.
And the protein is something like a Freund syndrome. Because actually the cord is all around compressing. CSS space is totally obliterated. In one place, CSS it cannot be seen at all in that, underneath the dura.
Sir, will that cause xanthochromia also?
Yes.
Yes,
CSF protein more than 150 milligram can produce xanthochromia.
So how long did you give the treatment, sir?
The second MRI, video was taken on the 5th day of giving IVMP. 5th day. So she has a good improvement in 5th day. But as you said correctly, sometimes these people will not respond to steroid very much. Some of them do require even rituximab also. I had a patient with IgG4 who come with ophthalmoplegia. And even on steroid, I put then subsequently on azathioprine because she is a young lady wanted to become pregnant. Even on that thing, she worsened. Still developing one more extra plan, I was getting affected. So I put her on rituximab. So some we cannot predict which will or not. So most likely the lesion in the cervix is also IgG. That improved remarkably short course of steroid and remained quiescent for a long time. So all immunological diseases, what I personally feeling is that some other environmental factors are innate, which determine whether the patient improve or not. That MS patient florid thing, some will not develop florid thing, but not. Some MS patient would not lapse. Some other treatment recurrent. So any other factors are regulating the immune response of the individual.
So before starting methylpred, should we not?
Please.
Sir, hello, sir, hello.
Please.
Sir, before starting methylpred, sir, is it not wise to rule out tuberculosis in this case?
I did not get the question. Before starting
methylpred, sir.
Yeah.
So should we not rule out tuberculosis?
CBNAT was negative.
CBNAT, okay.
Yeah. In fact, your sound speaking. Before starting methylpred, do we have to rule out other conditions?
Yeah, tuberculosis. What I meant was.
Yeah, exactly. Yeah, right. That is why send this thing.
Okay.
Reverse negative. That tuberculosis and that's all I sent.
Says oral steroids, how long do we give, sir? Oral steroids.
I put the patient immediate prednisone, but it is now oral. The patient shall be
very high ESR.